So I'm getting harder and it's getting harder and harder for me to talk about this because actually clinically this is really, really challenging. We have so little to offer these men. At the moment, we talk to them about smoking cessation, and in fact, almost all of them have quit within a few weeks of being told they have silicosis. We offer them exercise classes, but you try asking a 28-year-old to go to a pulmonary rehabilitation class where they're doing exercise classes with people in their 60s and 70s with COPD, and it's they don't want to go to that, and you understand why. We assess them for oxygen, and we refer them early for lung transplant. We give them advice about work, and they're advised that the best possible thing for their health is for them to give up their job, but that has real consequences. Most of them have got young families, and most of them, this is the only job they know, and a significant proportion of them don't speak good enough English to be able to do jobs which require them to speak English on a sort of regular basis. And we provide them with financial advice about industrial injury disablement benefits and about medical legal compensation. There are trials of therapy we can do. So there is anecdotal evidence that steroids might be helpful, but steroids carry with them a huge range of side effects. And the last thing we want to do is to make someone osteoporotic, give them mental health problems, and make them gain weight, because all of those things will count against them if they go on to have a lung transplant. There is some evidence that doing a whole lung lavage, when you bring people into hospital, you give them a general anaesthetic and you wash out their lungs, may improve the radiology. There's less evidence it improves their outcome, but it is something that we are trialling in a small group of people. And we can give them antifibrotic treatment like nintedanib, which is used for other fibrotic lung conditions. And as I said, we refer them early for transplant. There's been no transplants done in this country for this disease as yet, and the outcomes are quite varied from other countries because of the silica in their lungs. They're quite difficult to get the lungs out, and so they have a high risk of bleeding, complications in the surgery. And the other thing is that transplant isn't a cure. It gives them additional years, but it might prolong their life by 5-10 years, not more than that. So I could talk about this for a long time, but I just thought I'd pull out a few key issues. So we know that this is a preventable disease. If people didn't work in these conditions and didn't do this job, they would not have the disease. And we're seeing short latency disease and accelerating acute disease, which we know is associated with extraordinarily high exposures. They're young and sick workers. There's no treatment. There's no guidelines anywhere in the world about how to treat these patients. In the UK, the size of the exposed population is completely unclear. No one knows what the denominator is, and therefore we don't know how many cases we're going to get. And we think that there are lots of people who are asymptomatic who haven't come forward. There are people who've got symptoms but are misdiagnosed as sarcoid, and there are people who have got symptoms but who haven't sought medical attention because they've attributed it to, for example, their cough to smoking. But what I'm sure about is that numbers are going to increase. And if we just think back to those Australian numbers, it's not hard to imagine why. The current UK health surveillance programme is not going to identify the cases, and we know from the people that we've seen that it's not even being done. So the current health surveillance in the UK will start with a chest x-ray after 15 years of exposure. It's recently been updated to say you can do it much sooner if there's a risk of accelerated disease, but there's no guidelines about when that should start. And actually, I don't think there's any data to say when that should start. And we know from Australia that doing a chest x-ray, you're gonna miss 50% of cases if you do a chest x-ray. Really, they all need to have a CT scan on if you want to find all the cases. There's lots of variation in conditions in the workplace. So I was told this week by someone who works for a large, very well-known kitchen manufacturer that they have done a chest x-ray on their entire workforce and there's no cases of silicosis. Whereas I have companies where I've seen all of the people who are working in that finishing process and they all have disease. So we don't understand if the product can be used safely in the UK in line with the conditions that this large manufacturer are being used. And so it's unclear if given certain settings it can be used safely. The industry is starting to introduce low silica content alternatives, but it's unclear how safe they are. And currently is not reportable under riddle. So if you get a case of silicosis, it doesn't need to be reported. So we're not really counting the cases of silicosis in any sort of formal way. So the ban in Australia, there's quite a lot of discussion about this and how it arose. I think there are bigger conversations about how they had a change of government, for example, which I think this was one of the things that they picked up on. But options they discussed were a national awareness and behaviour change initiative and campaign, introduction of a licensing framework, regulation around high risk crystalline silica processes, or the ban. And then the ban was around all engineered stone, only those containing high silica content, or those containing high silica content plus introduction of the license. And I think the challenges of a ban are implementation of a ban, implementation of licenses. There's a real issue about labelling. So most of the slabs that people are working with, or high proportion, come from China. There are no checks on how much silica is in those products. So one of my patients said that, it has a hazard label on it and they just peel it off and put it in the bin when it comes in. And nobody, if they put a label on it saying it's low silica content, no one's going to check that. There's substitution with other materials of potentially equal harm, and fundamentally there's illegal working conditions, and there's a real failure to follow health and safety legislation and to perform inspections of these places. So a simple ban, I think, isn't necessarily as straightforward as it might sound. So what's being done in the UK? So at the Brompton, we've set up an open rapid access assessment for people. So if we get a WhatsApp message or an email from somebody saying, please, can you see me? I'm worried I have silicosis. We can see them directly. We liaise with their GP to get them seen, and we can see them within a couple of weeks. We've set up an MDT and a fast track transplant MDT to try and put heads together about best management, and we provide information for patients to share with their colleagues and ex-colleagues so that they can come in to see us quickly as well. We now have a go-ahead for British Thoracic Society national guidelines on silicosis, which should be starting in the next few months. And I'm part of an international set of state-of-the-art review in the being formed from the US with the ATS, and part of the Australia and New Zealand silica management guidelines. So by the end of the year, we should have some sort of best evidence about how to manage these patients. We're doing as much education as we can for clinicians in a range of specialties and trying to focus on the risk of misclassification of sarcoidosis. There's trying to raise awareness through the media, both to highlight the issue, to make people consider what kind of worktop they want, and to identify cases by people coming forward. And there are other things in place like preventing future deaths report. We record all our cases to SWORD, which is the National Reporting Scheme for Occupational Diseases, as do the other occupational lung disease consultants around the country and other occupational physicians and respiratory consultants. And we've just been given funding to set up a national registry so we can enter more data into that and follow patients longitudinally. There's lots of us in the UK who are collaborating both nationally and internationally to try and set up research projects to try and work out how to prevent all aspects of this really, but including prevention of disease. Industry are carrying out education and training and exposure measurements in the workplace and looking at low silica content products. And there's lots of conversations being carried out on a regulatory level, and not all of these sort of fit under regulation, but I stuck them all under the subtitle. So there's an all-party parliamentary group on silicosis and that I'm part of, and then we meet regularly to discuss sort of various issues. The Health and Safety Executive are thinking hard about this and are doing sort of lots of projects on it, including, for example, the revision of the health surveillance programme to put in that extra clause about earlier X-raying. BOHS have put together some training material for people who work with engineered stone to remind them of the risks, to educate them about the risks, and to show them how they can protect themselves. I think really there needs to be a discussion about whether silicosis should come under riddle regulation so it's reportable. I don't think at the UK there's much of an appetite for a UK ban of the products, but there's certainly discussions which are ongoing about it. And finally, there are lots of financial issues. So and I won't go into them, but essentially some of these patients are really sick and are going to die, and they need a financial support pretty quickly because they've got young families. They're being made homeless, literally, when they can't pay, when they stop work because of their silicosis, they can't pay their landlords, they're being made homeless. And we've got one case exactly like that at the moment. So they need some sort of lump sum quite quickly, and legal cases take a long time to come through. And there's issues around how quickly their IIDB is processed, so that they therefore can't get a lump sum payment until that's done. So there's some of the legal firms who are interested in this are looking at that. I think really we're very much seeing the tip of the iceberg of the whole situation. And there's more to come, I am sure. And I just want to sort of credit really my team, and particularly Tamanna, who's at the back in the red shirt, who's our clinical nurse specialist, who is an amazing sort of advocate for patients and spends a long time trying to sort out how to make life a little bit easier for them. We wouldn't be able to manage without her, and neither would the patients. Thank you very much for listening, and I'm happy to take any questions.
Thank you very much, Jo. That was an excellent presentation, and quite sobering.